getting to zero, and I'll probably jump around slides that I think are kind of relevant from a case manager's perspective. But my goal for today is to give you guys a strong foundation of kind of where, kind of what direction the HIV world is going to, and kind of give you guys an understanding of why the HIV world is moving in that direction. And also just to kind of just add some lagniappe to this as well. A lot of what we're going to be talking about here to a certain degree is going to a certain degree apply to how we're handling Hep C as well. So just kind of, so that this way I'm going to drop seeds in your minds so that you can kind of understand, well, this is the direction we're going with HIV. This is also, to a certain degree, obviously, you know, different diseases, different medications, that sort of stuff, but that sort of gives you a roadmap as to how we're approaching hepatitis C as well. So with that, no disclosures, and we're going to start talking about what to me is, without question, the most exciting concept of HIV that has come out in years. Prior to being able to say U equals U, I would stumble and fumble my way through treatment as prevention or TASP or you can't transmit HIV, and you know, and I've been saying this since 2011, since the first HPTN 052 study. I've been talking about what we now refer to as U equals U. But it took a non-person in healthcare, basically. It took somebody from the affected community, Bruce Richmond, to actually put these three characters together to form what is now what is a considerable movement, a movement like I've never seen before in the HIV community. And everybody here has heard of U equals U, obviously? Okay, super. I'm still stunned, and I go to rooms regularly where nobody has heard of U equals U, and that's important. It's important for me to be there. But so let's quickly talk about kind of U equals U, and this is a study. This is a slide deck that I use to talk to doctors. So if it's a little on the beginning or intro side, the core stuff is there. So of course we know the U equals U campaign launched with 4 large studies with thousands and thousands of serodiscordant couples, both MSM, hetero, homo, sexual folks, but there were 0 transmissions from sexual intimacy. And the way that what this graph is basically trying to show you here is here's your detectable viral load. With medications, it's going to reach some line here of undetectable status, and once it reaches that level of undetectable status, there's no risk, or the risk of transmission to your intimate partner is effectively 0. And that's super important to consider. The medical world says 6 months. It's really like 3 weeks, but 6 months is kind of the number they ask us to use. Right? So I advise them to use barrier or some sort of protection process prior to reaching out. These are the studies. This is the campaign. It's pretty remarkable. Again, 0 HIV-linked transmissions, hundreds of thousands of common sexual acts. We'll get into that in a moment. So probably the most important thing, and Dorian, and I have a quote here from Dorian Gray Alexander, who reminds me, because I naturally tend toward talking about the public health implications of U equals U, and I'm constant, because that's my inclination, that's the direction I go in, right? A public health person, getting to zero, getting to zero, getting to zero. That's constantly my way of looking at things. But I have Dorian, who reminds me, and again I have a quote from him coming up, that, excuse me, I have a little bit of a cold, that U equals U messaging really has the potential to reduce stigma. And that's the most important thing. For the first time ever, we've had messaging that's really kind of liberated people that are living with HIV with this guilt, with this quote-unquote shame, with this sense of feeling dirty, the stigma that has not only inhibited their physical life, but also their mental health as well as with the notion of possibly transmitting HIV. I will say that of all the people, when I've had to give a new diagnosis of HIV, usually the first thing that people will say is, I don't want to transmit this to somebody else, right? I don't want to have done what was done onto me, some iteration. I've heard every single person who said that to me. And so now we've effectively eliminated that with U equals U. Of course, now we're going to hopefully start seeing more and more people, right, go and get tested and get treated, because now people know that if they are HIV positive, that they're not going to be considered dirty or shameful or stigmatized, right? And if you think about it, the shame, if you will, or stigma, if you will, of infectious diseases goes back to the Bible days, right? So this is not, right, the Bible has stories, and this is also, please recognize, you should not be getting your Bible information from an atheist, but I am aware that there are infectious diseases that are in the Bible and that people felt stigmatized. So this is a very old process that humanity has experienced, this idea of shame or stigma associated with infectious diseases. I was down in Sierra Leone for 4 months working for the World Health Organization during the Ebola outbreak, and boy, was there stigma with Ebola. Boy, was there stigma with Ebola, right? So it's same thing with TB, HIV is the one we're at now. So again, now that people can see this U equals U campaign, we'll be able to increase demand for HIV testing. Obviously, increasing early initiation for treatment is critical and obviously very important, and I'm going to talk about that in a second. And of course, improved adherence. In all, 800, as of March 7th of 2019, 844 organizations from 97 countries have signed on to the U equals U messaging. That's amazing, right? Like, that's incredible, and something that we all need to be super proud of. So let's talk about stigma and HIV. And so this was a slide I had made, just basically, again, constantly underscoring the importance of infectious diseases on one side, stigma on the other, and in the middle is where you're going to find poverty. And so oftentimes say that the 3 number 1 killers in the world are HIV, TB, malaria. They're not happening in Sweden, right? They're happening in poor countries and poorly resourced countries. I'm happy to say this week that there was the first malaria vaccine that was actually introduced, and so hopefully that may be something that could be potentially literally life-changing. So these are a series of meta-analyses. Meta-analyses are studies of studies. So these are all individual studies, right? These are all, and the red line that you're going to see here is the accumulation, the summation of the variables to make one study. So you basically take a bunch of studies and then you do a statistic and you get what they refer to as a summary measure. So this is a study of studies, right? A meta-analyses are studies. So I'm going to show you about 4 of these. And what you're going to see is how intertwined stigma is with HIV. And so here when you look at stigma and HIV, you will see that these are all studies of people living with HIV. And what you'll find is that stigma is associated with lower antiretroviral therapy, right? So people who feel stigmatized have lower adherence, they have lower physical health perception, they have higher depressive symptoms, right? And there's higher levels of anxiety, right? So you can see how the importance of removing stigma is so important, not only just because it's important, it's the right thing to do, but it also has physical and mental health implications that are so incredibly important especially when you're looking at medication and medication adherence. But when you're thinking about mental health, it's incredibly important as well. This is an infographic that I think is so important, and it's specifically looking at women in U equals U. It's a hard graph to read, but I'm going to read all of them, if you guys will indulge me, because I think that you will appreciate kind of what the messaging is. So I'm going to start up here for power. It says the U equal U movement must rally to support women's rights and gender equality, and I would add equity. Treatment. Women living with HIV must have access to the full range of treatment options that exist both for themselves and their families. Differential access. Women living with HIV experience access to treatment and care differently around the world. The benefits of U equals U will never be fully realized until the inequity of access is addressed and solved. Breastfeeding. Women living with HIV must be supported to make the best choices regarding infant feeding, including more research on breastfeeding and vertical transmission. Let me just kind of add here that U equals U does not include breastfeeding. Right? We're all clear about that. It's very, very clear. That sexual transmission, we don't know if it works for IV use or IV drugs, but we know for breastfeeding, U equals U is not applicable. So this is mostly, if not exclusively, applicable to sexual or intimate acts, right? Surveillance, the undue scrutiny and control over the sexual and reproductive health and rights of women living with HIV must stop. Informed choices, U equals U has demonstrated that knowledge is power. Women living with HIV have the right to the best information available so they can make informed decisions for themselves and their families. Conversations, U equals U provides a supportive platform to talk about gender and HIV infectivity and risk and all the additional choices women living with HIV have, in relation to reproductive health. All laws that criminalize women living with HIV must end. U equals U is a powerful tool to make this happen. That's another very important point, is the decriminalization of HIV and how U equals U is going to help us finally decriminalize HIV, because I think that's the next frontier. I think we're moving in the world of HIV. U equals U impacts women living with HIV in multiple ways, and all of these must be appreciated and addressed. The concept of U equals U was proven in the bodies of women living with HIV seeking to avoid vertical transmission. This history must be honored and respected. Sexual health. Women living with HIV have the right to express their sexuality and to have sex in ways that feel good to them. And science. The lives of women living with HIV must be included in the development and of the scientific evidence that continues to support the U equals U message. I think it's a really important infographic, and I think it's one that's very important. So the idea that someone living with HIV who is both on treatment and virally suppressed and cannot transmit virus to an intimate partner is revolutionary and reduces stigma associated with HIV and people living with HIV. U equals U frees people living with HIV to live healthy sexual lives without the burden of guilt of transmitting the virus to their partner, and that's revolutionary. And here's Dorian Gray Alexander, who, and I show this picture all the time, no matter where I am, right? I will always show this. And it says here, U equals U means people living with HIV can live without guilt, shame, or fear of being sexually healthy human beings. We are not vectors of diseases, and prevention is a side effect of effective treatment. People first, all right? You're going to see me lean toward the public health side. So I just want to make sure that we're very clear that the stigma element of U equals U is incredibly, incredibly important, okay? And is very liberating and incredibly empowering. Is there anyone here that doesn't believe in U equals U? If you don't want to raise your hand and you want to contact me, please do so. I'd love to walk you through the science of it. I'm stunned when we show physicians and healthcare workers the science behind U equals U, and there's still this sense of not believing it.
Are you going to show us some of that science
Coming up next.
Okay.
Yes.
Quick question.
Yes.
Do you know if they're doing any studies looking at the amounts in breast milk?
No, I'm sure that they are. Yes, I'm sure. I don't know of any studies, and that doesn't hit my, like, the kind of the things I look on that I'm constantly surveying is looking at like social determinants and HIV and Hep C and stuff. I just see when the studies are finalized. So I'm sure somebody's working on it somewhere. I don't follow that field, but that's an important question. I'm sure they're trying to get to a U equals U messaging in breast milk as well.
I feel like, I know they have to do studies to make it, I don't know, but it seems like, I guess it'll make more sense to me when we look at the science, but it seems like if the science supports
I think I see what you're saying. Yes, it should be, but I think that the transmission of HIV by breast milk, you're going to probably have a bit more of a denser load of virus and a more direct access. That's why we know that it's not that way through IV drugs. But when you're looking at through sex,
yeah, I guess the amount of liquid, you're right, is so much greater.
Right. I think you're just seeing probably a higher density. When you're looking at through sexual transmission, I think that you're just seeing far less viral lows. That would be my kind of shooting from the hip kind of guessing.
Formula is just so expensive. Like, I wish that.
Yes. Yes.
And breastfeeding is wonderful. So
Yeah, of course. But it obviously just can't recommend that. Right?
Yeah.
Medical science. Okay, ask and you shall receive. That was the next slide. All right. Okay, so let's look at it. So here are some of the terms we use. Viral load is a measure of the amount of HIV in the body. Viral suppression is when antiretroviral is taken long enough to reduce the ability of the virus to make copies. Undetectable viral load. Someone on ART and their viral level in their body so low the blood test can't detect it. And untransmittable basically means HIV cannot be transmitted through sexual transmission when the viral load is below 200. So it's very important. 200 is the magic number there. All right, it's not the little blips that we see. Sometimes we get a blip of 50 or 70 or 20, right? Those are usually reflected. In fact, somebody can take their medicines for a whole year. They're going to come in and take their labs on Wednesday. On Tuesday, they forget to take their medicine. You'll see a blip on Wednesday. So just to give you an idea, and how important making sure those deliveries are on time, right? And it's important to have patients have a little stash of medications from when those deliveries aren't on time or when it falls during the holidays and stuff. Now, having a little blip over, it used to be that we would be obsessive about blips, right? I look back at my notes from like 8 years ago and I'm like, oh yeah, I can't believe I used to do that. But we didn't, I used to put somebody on a ton of medications because they used to have a ton of little blips. We now know those blips don't mean anything. They mean like, if I see a blip, my patient's like, yeah, I take my medicines every day, and I'll see a blip of 50. I'm like, dude, you got a blip. He's like, well, I didn't take it for the last couple of days before I came and got. I'm like, why? He's like, well, and then you hear the real story. But the importance here is understanding that people are going to be on HIV medications for the rest of their lives, period, right? There's no sugarcoating it, right? And I can tell just by seeing 1 day or 2 days of not taking their medications, their viruses immediately go up again. So this is really a Band-Aid, if you will, or a bridge until we get to a cure, ideally, or the next big step up in HIV medications are going to be what? Anybody? Not a vaccine, injectable medications that are going to be like once every 6 months, once every 3 months, stuff like that. That's going to be the next big. So Biktarvy was our big revolution, right? We got to Biktarvy, great. We got a dolutegravir, which is an integrase inhibitor. We finally got rid of tenofovir by putting TAF in there. We got rid of cobicistat, which was a problem. We got down to the 3 core medications, right? Great. Now we're going to be able to sustain everybody on Biktarvy for a long time until we get to the injectables, and that's going to be the next big kind of jump up.
Do you see that in the near future?
I'm saying 5 to 7 years.
Okay.
I mean, the studies. I mean, at CROI, I'm not showing any CROI. I'm showing a couple of prep CROI slides, but the slides from CROI that I was able to get my hands on, they're all still testing, and they're kind of dipping their toe in the water to make sure that they're looking at 2-drug therapy right now to see if that's even feasible. Remarkably, there was a 2-drug oral therapy of FTC and dolutegravir or something. Somebody just came out with a 2-drug therapy, which is really kind of a big game changer because it's always been 3-drug therapy, and I think it's going to be hard to get ID doctors to move to 2-drug oral therapy, but it's out. I saw it approved, and then, of course, the day it came out, I had somebody at my clinic already starting to push the medication on me, and that's somewhat stunning. But the next big thing, and I do see, to be fair, I do see that they're going to try to whittle away a medication, but 3-drug therapy just kind of was the number that happened in the early 90s. AZT, we overloaded people with AZT, we suppressed bone marrow, we said, wait a second, that doesn't work. They tried a second drug, which was I think probably a DDI, and that was somewhat toxic, and they were creating resistant viruses. And Dave Mushat, my former boss at Tulane, who's the chief ID at Tulane, will say he remembers the day when someone said, well, let's add a third and see what happens. And they added a third drug, and then boom, viral loads went down, people got healthy immediately, and there was no resistant virus. And here's a little bit of trivia. What was the first 3-drug-in-1 medication? Do you guys remember?
Was it a triplet?
Yeah, it was before triplet. It was called Trizavir. Trizavir, remember that? Trizavir? It was, God, I shouldn't have done that, right? It was AZT, I think it was abacavir, and it was like either FTC or DDI or something. I had one patient who was a holdout until like 3 years ago. He was on Trizavir. Like, I couldn't get him off of it, right? And those were, the reason why it's notable is that those were 3 nukes. We don't do 3 from one class anymore, right? You do mostly 2 nukes and then, a non-nuke, right? That was a tripla, or 2 nukes and then a protease inhibitor, but we stopped moving with the non-nukes. We stopped moving with the protease inhibitors, and now it's 2 nukes and an integrase inhibitor, and that's how we get to Biktarvy, right? Emtricitabine and TAF with dolutegravir, right? And that's where we are. So we're locked and loaded. So that's great news. And that's largely the reason why, to a large degree, you're seeing a lot of ID doctors kind of going, okay, cool with HIV, let's start to focus on Hep C, right? Because now we know, there's still a lot of issues with HIV, don't get me wrong, but the urgency of it has significantly, and with the work that you guys do, you guys are the unsung heroes, right? I'm the one that gets to stand up here and speak and whatever. You're the ones that are really doing all the work in the field, right? I say that all the time, and I mean it very honestly. Because it's your constant interacting and making sure people have medications, making sure that their needs are addressed, because it's more than just a pill, and it's more than just getting labs and seeing a doctor. It's the whole thing, right? It's housing, it's food, it's childcare, it's employment, it's transportation, it's all those things. And y'all are the conduit to that, and I'm going to show you some slides that document that. But when you look at, this is the history. So do you guys remember the Swiss statement? Remember in Switzerland in 2008? Guys, if not, this is a little bit of a history lesson for you. So before the big HPTN 052 study in 2011 came out, the Swiss came out and said, people with HIV don't transmit HIV if the viral loads are undetectable. And people were like, wow, I was one of those people. I was one of those people. Wow. I was working at NRPs at the time, which is the clinic on the West Bank, right? People were coming in, saying, I don't need to use condoms anymore. Like, no. The Swiss are a little too, like, they were right? They're going around having these victory laps, right? Because they totally nailed it. But the idea was too soon, and we didn't have nearly enough clinical trials like we do now, right? But hats off to the Swiss. They totally nailed it, and they were right. So, but then came the big HPTN, and it was number 052 study, okay? And very awkwardly named. That's why they have now partners and all the other stuff. HPTN 052. It's important to talk about it, so let me just explain to you real quickly, but I often say I remember where I was when, like, John Lennon died, and when the space shuttle blew up, and then 9/11 happened, right? I remember where I was vividly when this study hit my radar, and I was sitting in the basement of a pharmacy in Baton Rouge. I was setting up their antibiotic stewardship program in 2011, and I got a news flash from New England Journal, and my whole life changed, like my professional life, because I realized for the first time there's a path forward to getting to zero, and that was treatment, what now became known as treatment as prevention, or U equals U. So what did the 052 study show? Basically took 2 groups of people, right? Couples, serodiscordant couples. So one person with HIV and their intimate partner without HIV in one group, and another person with HIV and their partner who was HIV negative in another group. They can never replicate the study. Never. Can never be no IRB ever will ever allow this study to ever happen again, right? But in 2008 or 2009, when they were starting the study, we didn't know. So what they did was they said, okay, for this group here, the treatment group, we're going to put the person who has HIV on HIV medications. And the person here who has HIV, in this group, the control group, we're not going to give you HIV meds. We need condoms, education, come to the clinic, la 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 la. So they put this group on HIV meds, they put this group on no HIV meds. Again, this study can never be replicated again, right? And what did they found? They found that people who had HIV medications immediately did not transmit HIV to their partners. Now, there's a caveat here that I think is important. What you actually see is a little bit of a blip here, and you're going to see those blips in a lot of the other studies as well. And so the authors are always very clear to say that the transmission of HIV that occurred, so you'll see the word linked. The transmission of HIV that occurred in the treatment groups that were being watched occurred either when their partner was not virally suppressed, so that was early on, the transmission happened early on in the study, or especially when you look at partners and partners 2, people that had relationships outside of their primary intimate relationships, and those individuals that they had a relationship with were HIV positive and not treated. Are we cool with that? So when you look at and you can see the complexities of human sexuality, very complex, right? You're dealing with large groups of people, human sexuality, very complicated. So you can see these are nuances that are important to understand. But the point is that they had actually stopped this study early. It was a 5-year study. They stopped it in 2 years because there was 30 transmissions in the control group. There was 0 transmissions, linked transmissions, in the treatment group. Is everybody? That was the first. Holy, this is amazing, right? This is amazing, right? And these were the 3 cases that happened, and so initially there was like this 93% reduction, but now we're at U equals U, right? So the partner studies came about, heterosexual couples, between 2010 and 2014, 14 countries in Europe. A total of 11 HIV negative partners became HIV infected during the study, but none of these infections were phylogenetically linked. So does that make sense? So these were folks that kind of went outside of their primary partner, engaged in intercourse with another partner, and that partner ended up being HIV positive, and that was what was then counted. So here, if you look at about 1,200 couples that were serodiscordant, 58,000 acts of sex without condoms, there were 0 HIV transmissions. Okay. So there's no documented cases of HIV transmission among serodiscordant couples when the index partner was virally suppressed. So that's 2 studies. So, and this is looking at all of the sexual acts. You guys can't see them back there, but these are a lot of sexual acts. And these were all 0. Oops. This is the partner 2 study. And these were now MSM couples who had sex 77,000 times with 0 linked transmissions. I'll let you guys, those were all sexual acts that were documented. No HIV transmission that occurred. Opposites attract, again, were in discordant couples, MSM couples in Australia, Thailand, and Brazil. And again, no cases of linked transmission of couples occurred. And so when you look at HPTN, opposites attract partner and partner 2, we're talking about over hundreds of thousands of condomless sexual acts that occurred. The partners that were HIV negative were not on PrEP, so PrEP wasn't the reason why. Of course, that's going to be an important confounder that they need to eliminate. So PrEP wasn't the reason why. It was because we now know that the risk or the rate of transmitting HIV from a person who's HIV positive to a person who's HIV negative, whose viral load is undetectable, is exactly 0. We cool? All right. So I have a test for you guys now. This is like an old-fashioned test, right? It's like the old matching one. And I even went complicated. So there was 4 studies here, and I'm going to ask you guys to match them with the transmissions. And I actually added more transmissions, so like they do that, because I didn't want you to kind of figure it out. So we're going to just go for the first one, HPTN 052. Right, 0 transmissions. The partner study, right, 0 transmissions, amazing, right? Partners 2 study, again, 0 transmissions. And opposite, amazing, right? 0 transmissions. And so when you put all of these together, what we really have, in all honesty, is this whole concept, and with strong scientific background, that people who are living with HIV, whose viral loads are undetectable, are not able to transmit HIV to their intimate partners. And this is really this remarkable place that we're in. And this whole idea of U equals U. It's very empowering for people living with HIV. It removes the shackles of stigma that has followed people living with HIV for the last 30 or 40 years, and has liberated the sexuality of people living with HIV. We need to celebrate that. Then, Dr. Derry says it's really important because this is the way we're going to get to 0, and that's the second half of this lecture.
You mentioned earlier, right, about the importance of taking meds regularly, otherwise you start to see the blips in the lab results, right? But it seems to me that with all of these studies, right, there'd be multiple chances for many people within these studies to miss their meds. I'm just kind of curious how that sort of affected this, because what it sounds like to me is that even for those that aren't taking their meds regularly, if they miss something, if they can't get to the clinic, they're
So
still
here-
actually
Right. So here's a
showing
dirty
zero
little
transmission.
secret of HIV that we don't want. I'm telling you guys, but I expect you not to tell anybody else. Okay? People can skip their medications, and they're going to be fine. So I don't want people to know that. They can hang their hat on that. Like, we tell them, take your meds every day, every day, every day. That's the messaging they hear from us, right? But the reality of the situation is, they miss their meds here, they skip it here, they go traveling there, whatever, they're going to be fine. That's answer number 1. Answer number 2, and which is a little bit more nuanced and more biologically founded, is that when you look at something like measles, right? Measles in the news right now, right? When you look at something like measles, when you look at something like smallpox, all right? That only takes 1 or 2 virus. Like literally we can't even see, it takes electron microscopy to see a virus. We can't see it obviously with the naked eye. We certainly can't see it with a light microscope. You need electron microscopy. But those are called virions. 1 virus is like a virion, okay? Measles only needs 1 virus to be transmitted. That's why it's so highly transmittable, right? Ebola virus, you need 1 virus, 2 viruses for transmission to occur. HIV, you need a lot of virus for that to occur. Does that make sense? So let me give you the difference. Ebola transmits through the hands. So when we were in Sierra Leone, it was a no-touch culture, right? You immediately go to a no-touch culture. But things are still, Ebola is found in every single body fluid in humanity, right? So if you're cleaning up vomitus or stool or urine or whatever, you may, unintentionally, or my biggest fear was going to a supermarket and touching, so everything was always wiped down. I never used my hands. I'm an IED doctor. I don't like shaking hands anyway. I'm afraid of cooties, right? So I'm constantly doing that sort of stuff. My wife says, I'm always the person that will never hold the door open because I don't want to, or I'll wait for somebody to push the button on the elevator. I'm very good at doing that, right? And I didn't even realize I was doing it. She pointed that out to me. So when you look at Ebola, it's super easy. When you look at measles, it takes 1 virus to get right into your lungs. So it's a super easy route to get in, right? When you look at HIV, it's got to go through the genital tract, right? And there's a lot of barriers, multiple barriers along the way. And then once it gets into the system, it has to find the right macrophages, right? Those macrophages were found brilliantly in uncircumcised penises. Those macrophages there brought HIV directly to CD4 cells. So what was the best thing to do? Was circumcise men, right? Circumcising men was, next to treatment as prevention, was the most effective way of preventing HIV because that's where all the macrophages were kept, right? And that is actually brought the cells directly from the tip of the penis, right, where it's circumcised, directly to CD4 cells. Literally brought them right over there, right? So now, when you're looking at HIV, you need to have a density of virus to get through right? So that you can get enough of them to get to CD4 cells, to find those cells, infect those cells. Once those cells are infected and it reaches a certain number, then you can start having viruses that are produced repeatedly from those CD4 cells. It's a much more complicated disease process. Does that make sense? That's why HIV has been around in humanity for millions and millions of years. It just took a confluence of factors that happened in Africa with neocolonialism, and probably through the use of vaccines. They weren't really vaccines in the early 1900s, but they were using cowpox to vaccinate thousands and thousands of people at the time. And when you look at HIV and you break down HIV to its three most core parts, it's made up of three primates, so SIV, DNA, right? RNA, really. And when you look to see where those three primates live, it lives in one part of the world, in southern western part of Cameroon. Isn't that crazy? All this stuff got figured out on the North Shore, by the way. Right? Just to let you guys know, all of this stuff I'm telling you right now, the North Shore, the primate lab in the North Shore figured a lot of this stuff out, all right? So they figured out exactly what part of the world, and to tell you how they figured it out is crazy. They had to go around collecting monkey stool. It was crazy. Anyway, they had to walk through the forest collecting monkey stool. There are people who do that, and thank goodness for them, right? I love those people, right? God bless them. So when you look at those three factors of where those SIV viruses were found, that's where they found. Then it was brought over to the Congo, that what we now refer to as the Democratic Republic of the Congo, and that's where that super spreading process happened. And then from there, Haiti, and then the U.S. and the whole rest of the world. So, but it's been we see traces of HIV through history. Does that make sense? That's very likely where the Berlin patient came from, right? You guys all heard of the cure for the Berlin patient? You guys curious about that? You want to hear that in a sentence or two? How he's being cured? Here's how he's being cured. He is missing so the CD4 cell, so when the HIV virus comes to the CD4 cell, right, it releases two receptors. But just as the receptors are starting to fold up, two more receptors come out, right? And these receptors on the CD4 cell, this is called CCR5, okay? And what happens is that the virus needs to connect with that second receptor, the CCR5, to make the full infection happen to the cell. But if you don't have a CCR5 receptor, you don't have infection of the cell. That's how we got these so-called super long-term survivors, or we referred to in the 90s as the elite survivors. These are guys that were HIV positive but never went on to develop AIDS, right? So everybody goes in there and looks at them, finds out what's going on. They were all from Northern Europe. Well, when you look at it, there is a genetic deletion, or what's called an allele, was missing in the DNA of these Northern Europeans, and some people speculate it's probably because HIV probably came up, or something that looked like HIV came through early hamlets or villages of the time, decimating populations who were susceptible to it, but selectively, or selecting, using Darwinian selection, out people who were naturally resistant to it. They were missing that CCR5 gene, and then those people then propagated, right? And they gave birth and whatever, and now 1 in every 65 people, roughly, in Northern Europe are missing that allele. And so the guy from the two cases that you heard about, one in Croy, and then the other guy, the Berlin patient, what happened was that they both had lymphomas, and they had to get bone marrow transplants. So what they did was they selected bone marrow from donors that were missing that had that CCR5 allele that was missing. So what happened was when they replanted bone marrow into the person living with HIV, and the host who supplied that bone marrow was missing that CCR5 gene, what happened was that that original host's immune system completely flourished in the Berlin patient, right? And then this most recent patient from Croy. And what happened is now that their CD4 cells now don't have that CCR5. They don't have that mutation, or they have a mutation so that receptor is not there. That CCR5 mutation isn't there, and so when the HIV virus tries to come in and attack that that CD4 cell, it's not there. And so that's how that works. It's very, very elegant. Super long-winded answer to your question, but largely to show. What's that? No.
Okay.
Great question. That is not. Do not let your patients think that bone marrow transplants are going to become what happens moving forward. There's no hospital, no hematologist, no infectious disease doctor at all would ever consider that a potential treatment option. It's easier to take one pill once a day, U equals U, done. Your life is safe. You're not transmitting HIV to an intimate partner. You're going to be fine. In fact, I'm going to show you right now. Life expectancies are the same as people who don't have HIV, right? So let's move into the getting to zero. I got 20 minutes left, so I'm going to kind of jump through slides kind of quickly. But essentially, what we're seeing now, as viral load suppression increases, we're seeing declines in HIV. Think about that. That's a big deal, right? As we're seeing more viral load suppression increase, we're seeing declines in HIV. This is the blueprint for getting to zero. U equals U, again, hey Dorian, we talked about the stigma part. U equals U is the path forward to getting to more viral load suppression so that we can get a decrease in HIV. This is the future of HIV. You want to know the future of HIV? You're looking at it right here. This is it right here. Not bone marrow transplants, right? That's laying out, okay? This is the future of HIV, is U equals U, and understanding that with viral load suppressions, we get declines in incidence of HIV. So basically what we're showing is that since 1997, when there was, think about this, there was 25% of people were virally suppressed in 1997. Of course, these were 3-drug or more therapies. These are 8 to 10 pills a day, multiple times a day, horrible side effects. But as the medications got better in 2015, we're bumping up against 85% of viral load suppression. So we've done a great job, thanks to you. Okay, you guys are on the front line doing that. Okay, we have not seen that success with the Black community, so we need to do a lot better. Period. End of discussion. We are not going to reverse the HIV epidemic or get anywhere near the HIV epidemic until we adjust or we address racial and economic issues. Period. That's just the way that goes. This is Partners 2 study. We already talked about that. We talked about that. This is where I was trying to get to, which is we're at a point now where HIV, living with HIV, a person living with HIV has the same life expectancy as somebody who doesn't have HIV. And that's a big deal, right? Like, here's the 2 things I say to people that are living with HIV when I go make a diagnosis. 1, life expectancy is the same as somebody who doesn't have HIV. I never say your life expectancy is normal, right? I don't want to establish a normal for anybody. I mean, look at me, I'm not normal, right? So I never want to establish any sense of normality. So I always say, and I'm very, very specific about my words, that your life expectancy is the same as somebody who doesn't have HIV, or I'll say your life expectancy is the same as it was before you had HIV. Okay, and those are the words that I use. And then the second thing I always tell them, of course, is this. And then, you'll see this in a second, I then give them medications, right there on the spot, right? And then they're like usually tearing, then I drink the cup after them to show them that you don't have, you're not going to transmit. And if your family kind of freaks out, says, oh, you got HIV, you go, hey, listen, my doctor drank the water after I drank the water. If he can do that, then we can share utensils. It's a very powerful process. And when you do that, as you guys know, especially with same-day start, the loyalty to the provider or to the clinic is tremendous, right? The return to care, right, is unbelievable, and we'll show that in a second. These are our 90-90-90 goals. Everybody understand 90-90-90? We're fast track city. We're fast track state. You guys need to know this. 90% is by 2030, but we're going to blow past it. I like to think about 100, 100, 100, because that's just the way I roll. I try to push as much as possible. But by 2030, we're going to blow past these marks. 90% know their status, 90% on treatment, 90% of those are virally suppressed.
Do you know where we're at right now?
Do you know where we're at right now?
It's around 80% for viral suppression and the
Yeah. I mean, that's pretty remarkable. Think about that. That's, again, like, you know, I can get carpal tunnel patting myself on the back, but I'd rather get carpal tunnel patting yourselves on the back because you're the ones that are all responsible for that, right? So, and essentially, as we get more people who are covered through 9990, we're going to see rapid declines in HIV transmission, which is the crux of this. Look at countries that already reached 9990, Botswana and Cambodia, right? So if you develop good policy, right, even resource-poor countries, right? Nothing wrong with Botswana and Cambodia. I wouldn't think, and I've given this slide many times and people look at me and I'm like, yeah, that's the surprise, right? But when you look at good policy and create policy that targets populations, you can get what you want, right? And if you look at what the VA has done with hepatitis C amongst the veterans population, I don't have that slide to show you, but I usually show it in my slide decks. It's remarkable how the VA focused on it and how there was a response. What do you think is going to happen to Hep C in Louisiana starting after July 1st? There's going to be a significant decline of cases because Dr. Gee has focused her energies on Hep C and providing every provider who wants to prescribe Hep C medications will have Hep C medications, and that's remarkable. Louisiana is going to be the first state probably to eradicate hepatitis C in the state. That's really remarkable. Think about that. We don't have a cure for any virus except for hepatitis C. So I agree that we need to start focusing on that significantly, and that's certainly where we're headed. So it wouldn't be getting to zero lecture without talking about the amazing work that San Francisco has done, right? So this slide is like 2 years old, I think, already. But San Francisco was able to reduce their HIV transmission by 50% in 3 years, all right? They reduced their HIV transmission by 50% in 3 years by doing four things. Those 4 things were PrEP, making PrEP very, very accessible, making sure HIV testing was available everywhere, right? And then once they tested positive, what happened? Same-day start. So they made sure that same-day start was available. And they invested in case managers because we can't navigate our way through this archaic medical system plus all the social determinants of health that exists that you all are the ones that help navigate patients through so that we can get to the end. And the end there is obviously having undetectable viral loads. So let's quickly talk about PrEP. This was the original. I got 12 minutes. I can do this. This was the original study of PrEP, and essentially what we see now is that states that have the highest rates of PrEP have the lowest rates of HIV transmission. Think about it. PrEP works. There's no question about it, right? States that have the highest rates of HIV transmission have the lowest rates, states that have the highest uptake of PrEP have the lowest rates of HIV transmission. And this next slide shows more or less the same thing. These are states with the lowest amount of PrEP uptake, but they have the highest rates of HIV diagnosis. And these are states that have the highest PrEP uptake, but they have the lowest. They're in the negative values of HIV transmission. So we're trying to get Louisiana to do that. This is basically a study that it basically shows that PrEP users also become better healthcare consumers because they're going to the clinic and FQHC, what have you, to get their PrEP, and then they stop relying on urgent care, they stop relying on ER because they've established a relationship with a provider or clinic, and once they get in, it's really the whole idea of a medical home or medical model. And of course, there's no question that FQHCs are going to be the leaders for Medicare for all. When we transition to a single payer system, FQHCs are going to be on the forefront of that edge to lead that way. We're telling people to have sex without condoms, right? PrEP, Truvada is a great antiviral for HIV. It's an antiviral for HSV, herpes simplex virus. What's the word I'm looking for? HPV, right? Human papillomavirus. It's not an antibacterial, so it's not going to protect you against the big 3, chlamydia, gonorrhea, and syphilis. So we constantly need to be surveilling STIs all the time in our PrEP users. I always do. I find a ton of them. I treat them. No questions. I don't shame. Whatever. It's very matter of fact. People like coming to me because I'm very matter of fact about things. I don't shame them. I don't guilt them. I don't do anything. And I tell this to doctors all the time that we have to change the way we think about how we approach PrEP and then human sexuality. We need to do better with our Black and Latinx communities. We are failing completely. 1% of eligible African Americans and only 3% of Latinx community are actually on PrEP. These are stunning numbers. We have to do better. We can't get to a place of HIV. We're not going to be able to deal with the HIV epidemic until we deal with social, economic, and racial justice. Period. End of discussion. That's just the way it is. Okay. And this is a slide that shows it. These are slides from Croy. Right? These are cool slides. These just came out a couple weeks ago. This is the Discover trial. So this is basically looking at the new drug called Descovy. Soon, Truvada is going to go away. There will be no more Truvada, right? And we're going to be left with something called TAF, okay? Or also called Descovy, okay? Emtricitabine with TAF together are called Descovy. It's the new Truvada. So we've been waiting for the PrEP trials. This is the first data showing that the Descovy outperformed Truvada in terms of PrEP. That's great news, right? So we know that we're moving in the right direction. This is a great slide that at Croy they put together, which was really remarkable for anybody who doesn't prescribe PrEP. This is the rates of HIV transmission if you're on Descovy. This is the rate of HIV transmission when you're on Truvada. And this is the HIV transmission rates when you're not on PrEP, right? So we need to get everybody on PrEP and ultimately moving toward Descovy. Again, another study just basically showing that the studies are favoring Descovy over TAF, and that's what we knew. When we look at the two issues that Truvada causes bone mineral problems and renal problems. Here's the study looking at renal problems. Descovy outperformed in terms of renal, and Descovy outperformed in terms of bone density. So we know that Descovy is going to be the new drug. In fact, I just had a patient who came in. He's 58 and came in for his PrEP just a couple days ago. Just Descovy ready? No, we're really, really close to making it happen. And now he's a smart dude, so he plays with his PrEP. He takes it when he needs it, because if he takes it every day, his creatinine, his kidneys are affected by it. So he plays with it. So if he knows he's going away for the weekend, he knows that he's going to probably be having sex, he'll take his Truvada. If he's not sexually active, he stops taking his Truvada. And that's kind of how we're playing with Truvada right now until we can get to Descovy. I don't recommend that for anybody. That's just how I'm doing it.
I've had a few patients who are positive ask me if their partners should get on PrEP, and of course tell them that's a conversation you need to have with the provider. But I feel like it's like after I talk to them about U equals U, and I feel like because the messaging is that they should still get on PrEP, they feel like they don't believe U equals U then. Do you know what I mean? Like it's like,
sure.
Well, why would they get on PrEP if this is really true?
Sure.
I don't know what to say to those people.
Yeah, I mean, I usually just flip my computer over. I type in U equals U into a Google. I hit images, and then I scroll down all of the campaigns that undetectable is untransmittable. There's no reason for anybody to be on PrEP if they are in a primary intimate relationship with an HIV positive person or person living with HIV, and they're undetectable. There's no reason for that person to be on PrEP. I used to have people on PrEP. I've taken them all off PrEP. And there's not been any HIV transmission amongst any of my people, and hundreds of thousands of condom acts. So there's no need. And if they're not listening to you, they should. If they don't, I show them the computer, and if that doesn't work, then have them talk to the providers. But there should be nobody taking PrEP who is in an intimate relationship with somebody who is, and that's their only intimate. If they're having intimate relationships with other people, great, yeah, you should probably be on PrEP. But if you're in a monogamous relationship where you're not having intimacy with anybody else, and the person you're having intimacy with is undetectable, do not need to be on PrEP. Yes?
That's good that you mentioned it, because I do have a newly married couple.
Yes.
And they want to conceive.
Okay.
And their doctor actually told his wife to get on PrEP. But
HIV doctor?
but my client has his HIV under control.
Yeah, so this HIV doctor would love to have a conversation with that HIV doctor to see if there was something else that was going on. But there used to be a time when we would tell people that that for conception purposes, PrEP was appropriate. But those days were long, long gone. I mean, these studies are definitive. Like, the idea of being on PrEP, I mean, you guys probably remember this. There used to be some dude in Boston who used to sperm wash. Do you remember this? He would wash sperm. You would send him your sperm. He would wash the sperm. It would go back, and then it would be in vitro fertilization. It was ridiculous, right? It was none of our patients would have any access to that whatsoever. But I kept seeing a lot of my patients having kids, and I'm like, aren't you guys using condoms? But everything, like, the children were never born with HIV. Like, you know, we weren't at U = U at that point. But I have seen hundreds of conceptions happen, and there's never been any transmission that has ever happened. That was pre-U = U. We were starting to approach TASP, right, treatment as prevention in those days. But certainly since then, now that we're in U = U, I feel very confident that the idea of PrEP is just no longer and not necessary anymore. I think, was there another question in there? All right. Quickly, let's just go over Test and Treat. This was a movie that Graham and I filmed. So these are not real patients, right? So these are a movie. And this is just a movie, me showing kind of other doctors how to talk about U = U, how to talk about and how to talk to a patient and how to take their medications on the first day. So it's called Living Positive. We're going to be releasing it here fairly soon. We're showing it at the Public Health Film Festival that WHIV is doing in Tulane in a couple of weeks, and then after that we're going to be able to release it. But the idea being that it's important for us to start medications the day of diagnosis, and this is just a lot of data just showing that there's been decreased mortality in clinics in Haiti. There has been faster viral suppression, of course. This is another study showing faster viral suppression. This is Crescent Care showing that there was faster viral suppression there. Same day start. This is a study from Haiti again showing that not only was there faster viral suppression, there was decrease in mortality. This was looking at retention and care, which we were talking about. This is the next slide deck that we're going to look at, is that there was a greater retention and care, and that people's general health were improved. So it's unbelievably important, and this is retention and care, another study showing retention and care. When you go in, you tell somebody that their life's not in danger, that they have life expectancy of somebody who doesn't have HIV, that you're going to take a pill right now, and you're going to be virally suppressed, you're not going to transmit HIV to your intimate partner, and then you take them around and you introduce them to all the smiling faces. Ask Cameron how many times I just bring somebody down, I knock on Cameron's door, I bring him in, I'm like, Cameron, this is Mrs. So-and-so or Mr. So-and-so, new diagnosis of HIV. They get to know Cameron. Look at Cameron's face. Who doesn't love a face like that? Especially a smile like that. And then that's how we get them connected. And once they're there for their time that they're living in New Orleans, right? And then lastly, let me just go over just case management, because I think it's really important. Case management is, or viral load suppression is retention and care. Retention and care is viral load suppression. And these studies basically just show that suppressed viral loads occurs when there is obviously retention and care. And this was a study that looked at same-day start as well as linkage to care and retention. And of course, the same-day start far, far, far outperformed the usual care. There's another meta-analysis that showed that we have a greater likelihood of viral suppression and retention to care if we can get people into care within the first 3 months of diagnosis. This study more or less says the same thing. This was a study that I saw happening. I was around it, but I'd like to show it. This is it looking at in Sierra Leone, in Liberia, and they were doing a study in Freetown where I was. That's a picture of me. And when I wasn't doing Ebola, I was focusing on HIV work. I was working for World Health Organization, so the UN AIDS pulled me in whenever possible to help them do HIV work. So I was constantly finding people living with HIV when I wasn't doing Ebola stuff. and then finding people with HIV, making sure that they were following up to care, getting to their clinics, appointments, medications. And the point of this study was, even in the middle of a historic retention of care remained very high when people really focused on that level of retention and care. And again, this basically shows that undetectable viral loads decline the longer it takes for linkage to care. So the longer it takes for linkage to care, the more likely you are going to get undetectable viral loads. But if you can get people in within 0 to 14 days, we're getting undetectable viral loads. So linkage to care or retention in care is suppression of viral loads. So we have suppressed viral loads, and I show you all those graphs showing all the viral suppression. That's because we have folks like you guys that are making sure that folks are coming back. Missed appointments, you guys are calling, finding out where they are, making sure that they get their medications, making sure that the refills are done, all that stuff. And it's folks like myself, all the other HIV providers in this community who should be constantly saying thank you guys so much for the amazing work that y'all do. So with that, I think I am done. Any questions? Oh, and then of course, here's how we're going to get to HIV transmission, to reduce it by 50% using the San Francisco model. Again, increasing rates of PrEP, testing, same day start, and then obviously case manager, retention, and care. So with that, I think I'm done. 1 minute over, sorry. You guys have any questions? No? Cool. Thank you guys.